here in Geneva. My name is Tariq, and I welcome you for our press conference on the outcomes of emergency committee meeting regarding the epidemic of Ebola Bundibugyo virus disease in Democratic Republic of the Congo and Uganda. Very warm welcome to everyone online, but also to journalists who are here in our press room with us, both journalists who are accredited journalists at the UN in Geneva, but also journalists who came specifically for the ongoing World Health Assembly that is taking place this week here in Geneva, both in the UN and WHO building. I will introduce our speakers and then we will open the floor to questions. We will be taking questions from the room first, and then also we'll take a few questions from journalists online. With us, we have, as always, Dr. Tedros, WHO Director General. We also have Dr. Mohamed Yacoub Janabi, who is our Regional Director for Africa. Dr. Chikwe Ghebreyesus is Executive Director of Health Emergencies Program for WHO. Dr. Marie-Rosaline Belizer is Regional Emergency Director and Incident Manager for this outbreak in our regional office for Africa. With us is also Dr. Abdirahman Mahamoud, Director for Health Emergency Alert and Response Operations. Anaïs Legon is a Technical Officer for High Threat Pathogens at the Health Emergency Program here in Geneva. We also have with us in the room Steve Solomon, our Principal Legal Officer, and Dr. Vasi Morty, who is lead at interim of Research and Development Blueprint. Online, we should have Professor Lucille Bloomberg, who is the chair of WHO IHR Emergency Committee on Ebola Bundibugyo virus disease outbreak. We also have Dr. Jean-Marie Ocrobello, who is a vice-chair of the WHO IHR Emergency Committee. We should also have our representative in the Democratic Republic of the Congo, Dr. Anne Ansia, and she should be also able to join and give us update from the field. With this, and we should also, let me not forget, we should have online Roberta Andreghetti, who is focal point for emergency health, for the Emergency Committee and International Health Regulations. With this, I'll give the floor to Dr. Tedros for his opening remarks.
Thank you, Tariq. Thank you to our ACANU colleagues for joining us today in person, and to other members of the press online. Good morning, and hello to everybody, and thank you for joining us. Early on Sunday, I declared a public health emergency of international concern over an epidemic of Ebola disease in the Democratic Republic of the Congo and Uganda. This is the first time a Director General has declared a FIC before convening an emergency committee. I took this step in accordance with Article 12 of the International Health Regulations after consulting the Ministers of Health of DRC and Uganda, and in view of the need for urgent action. I determined that the situation was not a pandemic emergency, which is the new and highest classification under the amended International Health Regulations. After declaring the FIC, I immediately convened an emergency committee under the IHR, which met yesterday and agreed that the situation is a public health emergency of international concern, but is not a pandemic emergency. WHO assesses the risk of the epidemic as the high at the national and regional levels and low at the global level. So far, 51 cases have been confirmed in the DRC, in the northern provinces of Ituri and North Kivu, including in the cities of Bunia and Goma, although we know the scale of the epidemic in DRC is much larger. Uganda has also informed WHO of 2 confirmed cases in the capital, Kampala, including 1 death among two individuals who traveled from DRC to Uganda. An American national who was working in DRC has also been confirmed positive and been transferred to Germany. There are several factors that warrant serious concern about the potential for further spread and further deaths. First, beyond the confirmed cases, there are almost 600 suspected cases and 139 suspected deaths. We expect those numbers to keep increasing, given the amount of time the virus was circulating before the outbreak was detected. Second, the epidemic has expanded with cases reported in several urban areas. Third, deaths have been reported among health workers, indicating healthcare-associated transmission. Fourth, there is significant population movement in the area. The province of Ituri is highly insecure. Conflict has intensified since late 2025, and fighting has escalated significantly over the past 2 months, with over 100,000 people newly displaced. The area is also a mining zone, with high levels of population movement that increase the risk of further spread. And fifth, this epidemic is caused by Bundibugyo virus, a species of Ebola virus for which there are no approved vaccines or therapeutics. In light of all these risks, I decided it was urgent to act immediately to prevent more deaths and mobilize an effective and international response. I would like to thank the government of DRC, the National Institute of Biomedical Research, the National Institute of Public Health, and the local health authorities in the affected areas for their leadership and cooperation. I also thank the government of Uganda for postponing the annual Martyrs' Day celebrations, which can attract up to 2 million people because of the risk posed by the epidemic. My thanks especially to His Excellency President Museveni for taking this action. WHO has a team on the ground supporting national authorities to respond. We have deployed people, supplies, equipment, and funds. To support our response, I have approved an additional $3.4 million from the Contingency Fund for Emergencies, bringing the total to $3.9 million. In the absence of vaccines and therapeutics, there are many other measures countries can take to stop the spread of the virus and save lives, which the Emergency Committee has outlined in its temporary recommendations. To say more, I'm pleased to invite the chair of the committee, Professor Lucille Bloomberg, from the University of Pretoria in South Africa. Professor Bloomberg, thank you for your leadership at this time, and over to you.
So good morning, DG, Dr. Tedros, and members of the media. The first meeting under the International Health Regulations of the Ebola Emergency Committee took place last night, and I would like to thank the members and advisors on this committee, the Vice Chair and the Rapporteur, for convening at such short notice and sharing their expertise and experience in responding to this meeting and the call to respond to this outbreak. I'd like to thank the WHO Secretariat for their support and excellent work. We recognize the DG's swift action in response to Ebola by declaring this a public health emergency of international concern, and the members voiced their strong support for the continuation of this as a public health emergency of international concern. The committee was informed by input from the two countries currently experiencing Ebola outbreaks, the Democratic Republic of the Congo and the Uganda, as well as the WHO Secretariat. We acknowledge the country's honesty and transparency and recognize the many activities in response to this outbreak. I would particularly like to applaud the excellent work of the research institutes in both the DRC and Uganda in rapidly identifying the strain as Bundibugyo through genetic sequencing. Our deliberations around recommendations were considered in the context of the many challenges of this outbreak, the scale of the outbreak, the less common Bundibugyo strain, for which there are no available specific drugs and vaccines, and diagnostics required are different to those that have been used in previous outbreaks of Ebola. The context of the outbreak in the Eastern DRC and the humanitarian crisis needs and security challenges, highly mobile population, close proximity to many borders, the need to protect healthcare workers, and the need to continue important other programs for diseases such as TB, malaria, maternal and child health are highly considered. The WHO and partners, and like to recognize Africa's CDC, have mobilized in support of existing rapid responses by the DRC and Uganda, together with many partners. However, resources, additional people, many resources, research and development of countermeasures is urgently required. The director, the DG has, I think, outlined the important traditional outbreak responses that need to be intensified. Surveillance, identification of contacts, the need for infection prevention and control, protection of healthcare workers and families is absolutely paramount, as well as protecting lives and livelihoods. We need to support the rapid development and research around countermeasures. And the resources required for this. The current situation and criteria for a public health emergency of international concern have been met, and we agree that the current situation does not satisfy the criteria for a pandemic emergency. The people in the area and those who respond need to be kept safe and allowed to be able to do what they need to do in a critical time such as this. I would like to acknowledge the unique role of the WHO in its convening and organizing power for responding to these outbreaks. The role of the media as an important partner in communicating is absolutely critical. I thank you.
Thank you. Thank you so much, Dr. Bloomberg. And Tariq, back to you.
Thank you very much, Dr. Tedros and Professor Bloomberg for these initial words. We will now open the floor to questions, but just maybe to signal to everyone that unfortunately Dr. Anansia, who is our representative in Democratic Republic of the Congo, is not able to join us. So there are lots of hands already on the Zoom, but we will start with 3 questions from the room, and let's start with Catherine Fiancan.
Thank you. Thank you so much, Tariq, and thank you to Dr. Tedros and his team for organizing this press conference on Ebola. My question is related to vaccines and drugs that could fight this form of Ebola. We've heard yesterday that the representative of WHO in Bunia spoke about 2 months in order to find identify a vaccine, and they spoke also about trials. So could you please elaborate on that and give us more details? Thank you so much.
Thank you very much, Catherine. If it's just possible, just introduce yourself once you ask questions, so everyone knows.
Catherine Fiancan, Bokonga, France 24.
Thank you very much, Catherine. I think we can start with Dr. Morty, who is a lead acting lead for the research and development blueprint.
Thank you for the question. So the R&D blueprint is fully activated to accelerate research and development for medical countermeasures in this context. We've been ongoing for many, many years through previous outbreaks. So as DG said, I would like to start before going into the R&D by saying that I think the important statement to make is that we must really scale up intensive care, patient referral pathways, and prepare for a fairly promising pipeline in terms of therapeutics. So there certainly is hope along the way. Clearly, we do not have any approved vaccines for Bundibugyo. So the question was about the pipeline for Bundibugyo. There is a RSV Bundibugyo vaccine. So this would be the equivalent of Ervebo, which would be specific for Bundibugyo. There are no doses of this which are currently available for clinical trial. So this needs to be prioritized as the most promising Bundibugyo candidate vaccine. The information that we have is that this is likely to take 6 to 9 months. Before that, there is another candidate vaccine that is being developed that is based on the ChAdOx1 platform, so the same platform that was the AstraZeneca vaccine, but with Bundibugyo as the insert. That is a collaboration between Oxford and the Serum Institute of India. They are manufacturing that as we speak, but there is no animal data to support that. And so it is possible that doses of that could be available for clinical trial in 2 to 3 months, but there is a lot of uncertainty about that. And it will depend on the animal data as to whether that is considered a promising candidate research vaccine for Bundibugyo. So that's what I would say about the pipeline now. Thank you.
Thank you very much, Dr. Morty. Anaïs, would you like to add something?
No, just to reiterate a very important point that Vassi made. Our priority right now is to help set up the platform, starting with safe and optimized treatment center, good patient referral pathway to ensure that every single suspected case can be early detected and cared for while we are preparing for upcoming trial on promising candidate therapeutics. I think that's what is very important for everyone to remember. And this is being done as we speak. Thank you.
Thank you very much, Anaïs. And Professor Bloomberg and Dr. Okwobele, if you want to come at any point, just please signal on Zoom and we will give you the floor. Let me look again at the room. Rory, please.
Thank you. Rory O'Neill at Politico. I was wondering if you could comment on the decision by the US to impose a travel ban on Uganda, DRC, and South Sudan, and whether you have any advice or recommendations for countries with more direct links to travel links to those countries on whether that would be an appropriate public health measure to take. Thank you.
Thank you, Rory. Dr. Mahamoud, would you like to start?
Thanks for that question. Well, WHO recommendation for a long time is evidence and science-based and solidarity. For some time, we know what works. What works is contact tracing, monitoring those contacts, isolation, and immediate referral. Give you an example, like Uganda has done an incredible amount of work in tracing all the contacts and putting them in an institution or home quarantine and monitoring them. So we encourage all contacts, and our recommendation, we'll hear from the emergency committee what the recommendations are. All contacts, all cases should not travel. So we would like to, all countries, and appreciate what they have done so far. That's the first step of defense in terms of a global health security. Second element, countries are doing point of exit screening. Both Uganda, DRC are already doing that. So in support of the activity done by Uganda and DRC and going in this humanitarian conflict area, supporting them is the best medicine for the entire world in support of solidarity of DRC. It's a complex, as DG said, hundreds of thousands displaced population, insecurity, travel restrictions. Countries have sovereign, they do their own risk assessment, but they do have to provide to us the justification and the rationale behind their mandates. And we are seeing more and more countries. But currently, our top priority is to work closely with DRC in ensuring all the contacts are traced and all the patients suspected are put in the clinical pathway in safe environment and with the best care provided.
Thank you very much. Looking if anyone else would like to add something. If not, we will move to one more question from the room.
Can I add something? I think it's important to remember and recognize how Ebola is transmitted. It requires direct contact with blood and body fluids of an infected person. So it's not casual contact. It's not airborne. I think we need to be aware of that. And this relates to travel restrictions, which are not supported under the IHR recommendations. And we've heard about contact tracing and quarantine of those.
Thank you very much, Professor Bloomberg, for adding that. Let's take one more question from the room. Nina Larson.
Thank you very much for taking my question. Nina Larson, AFP. I was wondering if we have any indication of how long Ebola has been spreading for, or how long it had been spreading for before it was detected, and if you have any response to U.S. Secretary of State Marco Rubio, who yesterday said that the WHO was a little late in identifying this current outbreak. What role do you see that WHO had in that detection, and what impact do you think the U.S. cuts may have had on the speed with which this response happened? Thank you.
Thank you, Nina. Maybe we start with Anaïs.
Thanks. This is an important question. I think a lot of people have questions around that. So regarding the detection of this outbreak, again, I would like to remind everyone that the surveillance starts within the communities and start with the health authorities in every single country. As soon as WHO was aware of the signal, support was provided to DRC to investigate as quickly as possible. And this ended up with a confirmation late last week. Investigations are ongoing to ascertain when and where exactly this outbreak started. Given the scale, we are thinking that it has started probably a couple of months ago, but investigations are ongoing, and our priority is really to cut the transmission chain by implementing contact tracing, isolating, and caring for all suspect and confirmed cases. I defer to my colleagues for the other question.
Thank you. Dr. Janabi, would you like to add something?
Yeah, on top of that, I think it's important first detecting outbreaks such as Ebola in a complex setting like Ituri province in the DRC is inherently challenging. Surveillance systems rely on a combination of community reporting, local health facilities, lab confirmation, and a partner coordination. So in remote or insecure areas, it can take time for cases to be recognized, samples transported. I said the other day, from Ituri to Kinshasa is 1,700 kilometers. So until diagnosis is confirmed. So it's very important to emphasize that primary responsibility for detecting outbreaks rests with national health authorities as part of the international health regulation framework. So the WHO role is to support countries technically, operationally, and with coordination so that signals are rapidly investigated and confirmed. I just wanted to add that.
Dr. Mahamoud?
Thanks. Just to build on the Anais and the point raised by Dr. Janabi, is to put this in context. this outbreak is happening in a highly endemic other diseases that present similar symptoms from malaria, dysentery, and all other. So that index of suspicion, we've been picking signals from here. And yesterday we heard from the DRC authorities where their ongoing investigation are almost right now being completed. What they told us yesterday was on April 20th, there was a death of a patient. Always there's a spillover, there's a first case being detected, and then there will be a super spreading event either in a funeral or in a healthcare facility. So from the initial report they told us yesterday was April 20th, what's so-called the index case. And then the body was transferred on April 22nd. Why I'm spending some time here is just to put this in context because big statement needs to be supported with data. So April 20th, there was a death. April 22nd, that body was transferred. And May 5th was a super spreading event where we detected a social media report of deaths in the communities. The provisional government with WHO sent an investigation team on May to 12th, where they collected sample, did the EP investigations. Sample was sent to in INRP, and out of those 13 samples, 8 was confirmed. So between April 20th and May 8th, you can, in a highly malaria endemic zone, if you don't have that high index suspicion, if you don't have the right facility to test, you can, even in high income countries, you will have that delay in the start of an outbreak. So when action was taken, provisional government and the national government, and the results were available in 16 hours, in DRC, we just need to salute and appreciate what was done in a hardly complex conflict settings.
Thank you very much. And Dr. Belizer?
Maybe I can add to this.
Dr. Tedros.
Yeah. So this is very important, maybe on what the Secretary said. It could be from lack of understanding of how IHR works, and responsibilities of WHO and other entities. We don't replace the country's work. We only support them. So that's why there could be some lack of understanding. But then, of course, there is a delay in detection, and there are many factors here. Number one is security. I said it in my speech. Ituri province has been marred with conflict for some years, but the last few months was even very intense. There was very intense fighting. And the last couple of months, even more. In April, I think the highest number of civilians killed. And more than 100,000 people newly displaced, hundreds of thousands displaced in Ituri and live in camps. And displacement means not only displacement of the population, but of course, including the health workers. And health facilities cannot work optimally when there is conflict and when the health workers are also fleeing as part of course, the community which is displaced. So it affects the whole surveillance system. And not only that, it also affects access. So I think it's very important to understand in what situation is even the surveillance itself and all the things that the country does is done. The country has good capacity, by the way, they have good experience. This is the 17th, and there was recent outbreak that they arrested it, detected it early and arrested it quickly. But this is more complex. So that I think that's what we should understand, the Secretary or others. And then the second issue is, especially with regard to rapid field test, there was a problem linked to the traditional test we use. As you know, the traditional test is optimized with Zaire. And the same sample was taken and tested, but since the test kit is optimized with Zaire, it could not be detected. And then, of course, once samples were transferred to Kinshasa, and they tried to see if there are other things. The samples were transferred to the National Institute of Biomedical Research, INRB. It takes time. Imagine from Ituri to Kinshasa, and then checking all that is again adds to the complexity. But as you know, Bundibugyo has been detected, if I'm not wrong, in 2007. So it's very rare. That adds to the complexity and lack of optimization in terms of test kit. And then the third issue is, I think Abdi raised it, non-specific early symptoms. For instance, if you take malaria and typhoid, the early symptoms are the same. And the region is very endemic to those diseases. So the health workers, the early signs, they will associate it with malaria or typhoid, and they can't diagnose based on the symptoms. They may start treating. That also takes time. So it's very complex, and it's very difficult to follow a simplistic approach and say blame this or that. It's very difficult. But as far as we know, the country has capacity. They're trying their best, and they will do their best. But it's very important to understand the complexity, and before we conclude, bring all the factors into some kind of understanding of the complexity. It's not that simple. But from our side, we don't replace countries. This is the country's responsibilities, each and every country, but we support them. Thank you so much.
Thank you, Dr. Tedros. I understand that Professor Bloomberg would like to add.
I think the DG has spoken about Bundibugyo and the diagnostic challenges. So thank you very much.
Thank you. And I'm just looking if anyone else would like to say something. If not, let's go to journalists online, and we will start with Jennifer Rigby from Reuters. Jennifer?
Hello, yes, thank you for taking the question and for laying out the challenges in detection. I appreciate that. But I just wanted to check again if there's any guidance on whether any of the funding cuts from wealthy donor countries to DRC or to WHO have contributed at all to the delay in detection or the availability of tests for this rare strain, or are hampering the response now. Thanks.
I think it's a brief answer again. The way I answered earlier, we don't need to jump into conclusions before we understand the whole complexity. So it would be very difficult to associate it with funding alone. So I would be happy to look at this properly and understand what were the pitfalls, and of course learn from this and improve for the future. Thank you.
Thank you, Dr. Tedros. Let's take two more questions from online, and then we will go back to the room. We have Janice Q from Bloomberg. Janice?
Hi, can you hear me?
No, we can't hear you very well.
Sorry, I'm trying to adjust my microphone. Is that better?
Yeah, it is better.
Great, thank you very much. I was trying to find out Merck's Ebola shots. I know that this is specifically used for the Zaire strain, but will it be given to health workers protectively? And the new promising vaccine candidate that was mentioned earlier by Professor Bloomberg, is that also produced by Merck?
Janice, I think you got cut. Sorry for that. Maybe Dr. Morty can answer the first question that we were able to hear.
Yes, so with respect to Merck's Ervebo, which is the licensed Ebola Zaire virus vaccine, that is a vaccine for Ebola Zaire disease. It is not a vaccine for Bundibugyo. There is, as part of the R&D blueprint determination, we have our usual processes which have been activated and are underway. So we have a vaccines R&D technical advisory group. We have a therapeutics R&D technical advisory group. So these review any potential for research evaluation in outbreak context. Those determinations are underway. And sorry, I'm not sure about the other vaccine. I didn't actually hear any other vaccine that was being talked about, but happy to take more questions.
Thank you very much. Well, Janice, as we didn't hear the second question, you can send us email, as everyone knows. It's media@who.int. Let's take one more question from line, and if we can have Kai Kupferschmidt from Science, who is with us. Kai?
Yes, hey Tariq, thank you so much. Just a really short, easy thing probably, but in terms of getting confirmed case numbers, are you planning to have sit reps up or anything like that? It's been difficult to get a good understanding of how the confirmed cases are kind of accruing and where to check.
Thanks. So yeah, we are supporting, and when I say we, it's our colleagues in the field working very closely with national authorities to get this the picture a bit clearer, as you mentioned. And our first priority is obviously to help the DRC and the Institut National de Recherche Biomédicale to scale up their diagnostic capacities in the field so that it helps improving the management of suspected cases, identifying who is a confirmed case, who is not, and refers them to adequate treatment. So this is all working in process, and we hope to streamline information in support of our colleagues in DRC to get you a clearer picture, but also for everyone to understand the chain of transmission and being able to stop them, to stop this outbreak. Thank you.
Marie-Rosaline?
Okay. Thank you so much. Just to build on what my colleague Anaïs already said, effectively, we are working side by side with the government of DRC, but first we're also working to have the trust of the community. One thing we shouldn't forget in that outbreak is that this community are already being affected by a species of another Ebola. So now this community think that they are protected from Ebola. And there's a new species from which they are not protected. It's very important that the trust and the community should be there. So the team is already in the field in Bunia, in Butembo, in Katwa, in Goma. In Goma, we have a team that has never left Goma, doing all the insecurity that has been there. So we are in the field, we are doing the job together with the Minister of Health and supporting of that community. For treatment center, we already identifying together with the minister where we can place and do the treatment center. And you know, in WHO, what we really recommend to country is to have the response closer to the community in order to avoid resistance at a community level. So the treatment center are being places in where the outbreak is ongoing. So far, we have more than 13 health zones that has been affected in 2 provinces. So the outbreak is really spreading. It is a serious outbreak, but it is not this is something that we can control together. So other things also that we are really doing is working together in joint coordination with Africa CDC in order to put all the resources together and to avoid duplication in the field. Thank you.
Thank you very much, Dr. Belizaire. Well, we have time for a couple of more questions, and let's see here back in the room, Stefan. And if we can really have one question per journalist, so we take a few more before we close.
Thank you very much, Stéphane Bussa from Le Temps newspaper. I have a question for Professor Blumberg. You talked about your conversation yesterday within the emergency committee. Could you specify again the recommendations that the committee has made yesterday? Thank you.
Yes, thank you very much for the question. So our task was to decide whether this event constitutes a public health emergency of international concern. You heard from the DG that he had already declared this before the meeting. So we confirmed that we agreed with his decision and that this should continue. It satisfies all the criteria. We heard from the countries and about their actions and heard about many of the challenges. And our role is to provide additional or supported temporary recommendations to member states. That's around many of the things we've already discussed today, the need for R&D, the need to scale up surveillance, quarantine, and identification of contacts, safe burials. I think it's the usual outbreak response to Ebola, and we will be finalizing our recommendations to member states in the next day or so. But I think our prime aim was to support the decision and decide whether this is a public health emergency of international concern, and to consider where there's a pandemic emergency, but the former was agreed to. So I hope I've answered your question.
Thank you very much, Professor. Let's go to NPR. We have Jonathan Lambert online. Jonathan?
Hello, thanks for taking my question. It's about testing capacity. My understanding is that a shortage of lab test supplies and reagents was at least in part responsible for delays in confirming that this was Ebola. Can someone speak to the supply chain of testing and reagents and kind of where funding for this, as well as funding for the transport of samples, comes from and what might have caused the shortage?
Thank you, Jonathan. Anaïs?
Yes, thank you. I will try to be as little technical as I can. As you understand, the virus circulating is part of a genus called ortho-Ebola-virus. It's a different species that the one that is called Ebola virus. I know it is not very easy to understand, and we apologize for that. We have taxonomists helping us on that. So there are a number of tests that can detect Ebola virus, all right? And there are also tests that can detect all the different ortho-Ebola viruses. But this is different type of test, requiring different type of capacities and platform for testing. In DRC, the reference national laboratory that is based in Kinshasa is equipped with the capacity to test for all filoviruses, so all ortho-Ebola viruses and all ortho-Marburg viruses. In the field, they've scaled up capacity in the past because of the previous outbreak, to the support to the people who recovered from the disease, the ability to detect Ebola virus on a platform that can only detect that virus. Now, we are working with INRB and other colleagues to look at different platforms, and there is a promising one, the one that is being used, and we are working very closely with INRB so that we can get good validation data that would be able to be close to patient PCR testing, able to detect Bundibugyo as well. So we are using, sorry, they are using two different types of platform to ensure that detection is timely enough. At the same time, they are scaling up, and I think Marie-Roseline, and you will want to to complement that, along with a decentralized approach, bringing care to patients and to communities, it goes with the lab as well. It is critical that we reduce the delay. In terms of supplies, the conventional PCR you mentioned that is able to detect for all filoviruses, there is no supply of that. The manufacturer has been producing and orders are ingoing. Similarly to the other kit I mentioned. So for the time being, it's not a supply issue. We need to ensure that the right platform with the right data, obviously, arrives at the right place. And this is the work that is being done as we speak. Over.
Dr. Ghebreyesus, would you like to add something, or Dr. Belizer?
Thank you so much. In addition to what Anaïsa said, I want to ask another layer of complexity, which is the logistic and to transport this material from Kinshasa to Bunia. So for so many hours or days, we are waiting for flight to go, and the flight has been canceled day by day. Even today, our colleague of Africa CDC should have lead to Goma, and the flight has been canceled. I'm leaving today in order to join the team in the field tomorrow so we can go there together. So it is to say that this outbreak is happening in a very complex situation. Not only we have the insecurity, the trust with the community, we have also the logistic that is very important because we don't have other mean that to reach a Bunia that we live by airlift. So it's really important also that we share those kind of complexity. So regarding the supply, I think Gigi mentioned that the funding has been released as quick as 24 hours after the outbreak has been declared. So we also receive £1 million from FCDO, which we really say thank you because FCDO has been a partner who support a lot our work in the region. We also receive a fund from DG HERA. We also will be released $2 million from our regional emergency public fund that will be released to support. So the funding is coming, but now also when you have the supply, we need the logistic to be able in order to reach the field, which is very important. Thank you.
Thank you, Dr. Ghebreyesus.
Yeah, thanks for that. Just to connect some of the dots in many of the questions, whether it's around the laboratory itself, the supply chain, the request for CITREPs, they all lead to our absolute priority now is to identify all the existing chains of transmission. So this principle of identifying the chains of transmission is the same principle with every Ebola outbreak, and it's very important to get that right. And that's really where everyone is focused on at the moment, because that will then enable us to really define the scale of the outbreak and be able to provide, Kai, I think, ask for regular CITREPs, provide all of us the information we need both to manage the situation itself, which is then the priority, and then to scale the response in support of the excellent capacity that exists already in the DRC. We've been working with the Institut National Santé Publique, their new national public health agency, for a few years now, not only during outbreaks, but also in peacetime to scale their capacity, to grow their capacity, collaborating with them. INRB is a well-known, world-renowned science establishment already with a lot of capacity. My colleagues have referred to the challenges in logistics in the country, the humanitarian situation, the challenges with conflict. But between all of that, this is what we need to do. Now, the final point on this, on identifying chains of transmission, is the biggest lesson we've learned through all our Ebola responses is that we can't do this without prioritizing the community. So if we think that we are going to jump in there and solve all the problems, which is the instinct of many people working in this field, then we will not have learned the lessons of history. So the lessons are that irrespective of the pressure right now to go in, to do, to jump, that we have to work with the national institutions, the communities, the people. It is only through them and the confidence that we can build in them that we will be able to identify these cases, isolate them, identify the contact, isolate the cases, treat them, identify the cases, treat them, identify the contacts, isolate them. This is not possible without the community. So yes, there's a lot of pressure for us to answer all the questions right now, but I also solicit a bit of patience as we figure out what is going on, what we need to do, and deliver an appropriate response for this to support the people and the government of the DRC. Back to you, Tariq.
Thank you very much, Dr. Ghebreyesus. We are really approaching 12 o'clock, time we would have to stop. Let's take like the last two very short questions from Jamie and from Laurent. So Jamie first, then Laurent, and very short and one question.
Thank you very much. Dr. Ghebreyesus, you mentioned a question that I wanted to ask, but I just wanted to go back. So Madame Legon, you said that earlier that you're thinking that this has started probably a couple of months ago. And I note that the number of suspected cases is continuing to grow. I think it was 500 yesterday. Today it's 600, you mentioned. So based on those dynamics, what is your projection about how long this outbreak could last and how many people could be affected? Basically, to give us an early idea of what you just mentioned, Dr. Ghebreyesus, about defining the scale of this outbreak. What are your early projections about that? And I just wanted to ask another quick one, which sort of alludes to what you said. Infodemic and cultural disbelief came up from the WR yesterday. What do you do? We have a team on the ground around Bunia right now. What is being done locally to try to help address that infodemic, which is a term that Director General has used very often in the past, of course?
Thank you for putting me in the spot. I'm not a modeler, so I will not be able to answer your question precisely. We know there are teams ongoing. There has been a couple of modeling studies that have been published. Again, currently our understanding is focusing on what we can do now, cutting the chain of transmission and helping communities. And I think I'll differ on what's being done to my colleagues. That being said, we will not wait for this virus. So we are already scaling up. And as things evolve in the field with the capacity to diagnose, with the capacity to isolate, with the capacity to care, we will get a better understanding of that. But right now, our priority is to focus on supporting affected communities with the full response capabilities as close as possible to them. And I'll defer to you, Marie-Roseline.
And Dr. Janabi as well. So Dr. Janabi, then Dr. Balisek.
Yeah, thank you. Maybe what I can top up regarding the trajectory, it is too early to provide any precise projection on duration or total numbers. However, experience tells us that trajectory will really depend heavily on how quickly we can scale up case detections, like my colleagues have said, isolation, community engagement, which Chikwe just mentioned, and infection prevention measures. So at this stage, I think that could be the best response.
Okay, thank you. So we receive some modeling studies because we are working with some partners. One of them is the Imperial College of London, who just released some modeling studies. So based on that study, their estimation, we are talking about modeling. So they estimate that we can have two scenarios. One of them is between 400 to 800 cases that could be, and also one of them the worst scenario could be 1,000 cases. So they use the method of geographic spread. That is one of them. And the second method they use is the back calculation from death. So far, as a number of deaths, how many cases they can produce in the community. However, as my colleague said, they are estimation, and the reason why we are going in the field with my colleagues, epidemiologists, and also clinical care from HQ, in order to have a preliminary assessment that can give us an idea on what are we really talking about, what is the extent, and what could be really the starting date of that outbreak, so that can give us an idea on how we set up this response. But we already agreed that the response, we will scale it up. We will not wait to scale. We will really starting a very scale up our response. And after 2 months, if the situation is under control and there is a need to scale down, so we can scale down. So that means we are using the no regret policy and no harm policy of the emergency response program in WHO to scale up that response as big as possible. Yeah, thank you.
Thank you. And then let's have a last question. Laurent, please.
Yeah, thank you, Laurent Siro, Swiss News Agency. DG, you mentioned the volatile security situation in the eastern part of the country. Do you call the M23 to reopen formally the Goma airport in order for supplies to get faster? And linked to that, do you plan the deployment of international rapid response team and the IHL, or on top of the WHO team that you have already on the ground? Thank you.
Thank you, Laurent. I'm just looking who would like to. Tedros, Abdi, whoever.
I can start.
Dr. Ghebreyesus.
I'll take the second part of the question first on the deployment. We already have, firstly, we have a big WHO team already in the affected areas, like Rosalind said, in almost all of them. They've been there. It's the reason, together working with the national authorities, that we understand there's an outbreak at the moment. And we've been scaling that up, supporting the national authorities too, to deploy their colleagues from Kinshasa to Bunia. In addition, we have a joint cross-WHO team already on the way from both the regional office and HQ, depending on skills that are needed and capacities needed, and we will scale that as required over the next few days continuously. Now, the principle of how we respond to outbreaks has changed significantly over the years. So we will work with the local communities, identify where they have gaps before we fly down any troops to go and save them. The whole principle of how we work has evolved a lot. We respect the capacity that they have built. We identify any gaps, we discuss that with them before we start thinking about who is to go. So that's exactly what has started happening from the very first day, and how we are responding to the needs on the ground. I'll let the DG respond to the opportunities to maybe discuss the airport and general access to the Eastern DRC.
Yeah. As you know, the epicenter is Ituri, and of course, that's where the center is now. And colleagues have already traveled to Ituri, so there is no access issue. Based on how the disease spreads, if there is any access problem, then we will address it. But now we're focused in Ituri, since that's the epicenter. Bunia Airport, yeah.
Just to add on the point about the international surge, I just want to recognize all the health clusters and the mission hospitals who have been providing cares. Yaoundé Medical Hospital, where we had our American doctors providing, was attacked in 2002, destroyed. This team were there, came back, stayed there. The history of Ebola has always been defined by mission hospitals because the love and the compassion they have. From 1976, it was Yambuku, and now the mission hospital there. Just I want to recognize that the healthcare depends on a lot of health clusters that have been providing health service before Ebola, and they will continue to stay, and recognize all the faith-based who've been working in remote, difficult areas, providing care and health services to neglected and marginalized population.
And Dr. Belizer, you would like to add final word?
Just a last word to say that our team has never left Goma. We always have a team in Goma, and we always continue to provide our support to the population. And this is what we will continue doing, this outbreak in Goma. So we never left Goma doing all the insecurity happening. So we will continue staying to provide the security to the community we serve. Thank you.
Thank you, Dr. Belizaire, and thanks to all our speakers. This will bring our press conference to an end. We apologize to journalists who had their hands up online, also some journalists here who may have had more questions, but don't hesitate to contact us on media@who.int if we can assist you in any possible way. We will be sending the audio and video file of this briefing shortly to our media list. I give the floor to Dr. Tedros for his closing remarks.
Thank you to all members of the press, especially Akanu, for joining us today, and see you next time. Thank you.